What an intro. Good afternoon, everybody. For those who don't know me, my name's Liz McLeod, and I'm the Chief Executive of the very excellent East Metropolitan Health Service. At East, we recognise that the Whadjuk people of the Noongar Nation have an ongoing, continual spiritual and cultural connection to this land which we live, learn and work on today. And I'd like to respectfully acknowledge this ongoing connection and the Whadjuk people, past, present and future. Thank you very much to everyone for making the time to come along to our second East Metro Excellence Symposium, and a very special welcome to our presenters for 2020. I'm delighted to welcome Priya Cooper, who joins us today as our keynote speaker, and we're all very much looking forward to her presentation. We're privileged to have in our audience today several members of the community who are willing to help us in the development of our videos, and we thank you sincerely for your wonderful contribution. Thank you also to John Buchanan, who's kindly agreed to take on the MC role this afternoon, introducing the video presentations and facilitating the question and answer session with representatives from each team. Also welcome the people joining and watching this event via Microsoft Teams across all of our health services, and really celebrate how quickly we've embraced this new technology that makes events such as this still possible during COVID. At East Metro, we strive every day to provide our patients and community with amazing care. To help us do this, we carefully chose 6 values that guide everything we do: kindness, excellence, integrity, respect, accountability, and collaboration. Today, we're focusing on excellence, which drives us to continuously improve every aspect of our service, from providing safe and inclusive healthcare to being at the forefront of medical research and innovation. We're fortunate and proud to have an abundance of excellence occurring across East Metro, and this event provides an opportunity to feature teams that are striving to deliver on our vision: healthy people, amazing care. Kura mort, Mordich Kwabadak. Following a selection process undertaken across East Metro earlier in the year, the successful nominations for presentation today are the Mental Health Homeless Pathways Project from Royal Perth Bentley Group, Hospital Avoidance Response Team from St John of God Midland Public Hospital, Bentley Safety After Hours for Everyone, the Be Safe team from Bentley Health Service, Safe Peripheral Intravenous Cannulation Team at Royal Perth Hospital, and the Organ and Tissue Donation Service at Armidale Health Service. Today is a chance for us to learn from each other and simply celebrate achievements and excellence. I hope it inspires and encourages you to share what you do with our East Metro community at future events.
Well, 2020 being what it is, we have a series of video presentations for you today. But before we commence with our first presentation, can I just remind everyone that the event is being recorded today. Our first video is by the Mental Health Homeless Pathways team of Alex Jawaska, Kat Ahlers, Carla Francis, Noreen Mills and Amanda Stafford. Can we go to the video, please?
In 2019 to 20 alone, East Metropolitan Health Service cared for over 1,500 patients experiencing homelessness, many of whom were also impacted by a mental health condition. In an effort to improve the well-being and health outcomes of these patients, Royal Perth Bentley Group piloted a Mental Health Homeless Pathways project aimed at strengthening pathways to accommodation through collaboration with community organisations. Project manager Kat Ahlers brings 20 years of experience in social work, having worked in roles such as child protection, youth services, justice and fostering, as well as extensive experience in community homelessness services.
The 4 key goals of the Mental Health Homeless Pathways project. Number 1 was to identify people coming into hospital, whether it's coming into ED or in an inpatient setting, and identifying these people with no fixed address. Second and third goals were to build up community relationships with homeless services. Number 4 is to train and educate clinicians and health staff within the Housing First model.
Probably around 2 years ago, I realised that there were a lot of homeless patients being seen at a sister hospital, Bentley Mental Health, in the Bentley Mental Health unit. They were not getting the help there at that time that they needed to resolve their homelessness. And in discussion with the Bentley Mental Health Service, the Mental Health Homeless Pathways project was started and has detected and seen over 1,000 patients now in our mental health hospitals and wards.
Some of the great outcomes is that we've captured a lot of these clients on the by name list. The by name list is essentially a database that captures a snapshot of homeless people. So if Joe Bloggs turns up to Royal Perth ED, we look him up on the by name list. Oh, he's got a case manager in Fremantle. The name, the number of that case manager is on the database, so you can call them and get that handover.
The Mental Health Pathways project has been extremely important for the homeless patients that we see at the Royal Perth Bentley Hospital Group. It has opened the eyes, I think, of a lot of staff to just how many homeless patients they're seeing.
I think the Housing First has worked extremely well within this project. We've housed 27 people to date in their forever homes.
Yeah, my name is Gary Lewis. When I was in Bentley Hospital, I got help with home dressed, getting on home dressed. And I got priority listing too. 50 lives, 50 homes. I should be getting a home soon. A home means to me my own place, off the streets, nice and warm, family.
These are really chronically unwell people, the ones that people think, you know, they're not going to get housed, they won't be able to, be in a house by themselves. But as I said, the proof is in the pudding. 88% of people within the Housing First model in Perth have kept their tenancies and are in their forever homes, so it does work.
Yeah, Kat's a good woman. She's been helping me a lot, get my life on track, and she hasn't forgotten me.
So what I do differently is the through care model. So from hospital to home, I don't close cases. I don't give up on people because they don't engage. As we know with street present individuals, they don't keep appointments. A lot of them don't have phones, no way to contact. So I do a lot of assertive outreach to the hotspots of where these individuals may stay. So that's what I do a bit differently, that whole wraparound and housing first. People need a house first, and then you wrap around the supports. It's all around the client, isn't it? And getting the best outcome for that individual. And I think seeing the clients happy, housed, living their best life. The Mental Health Homeless Pathways shows excellence in the way that it surrounds the individual and the individual's needs, and it's very person and client driven. And I think just getting that basic need of a house before you can, unpack some of the rest of life's, difficulties. So I think that's key.
Are there any questions from the audience, please? Lucky I've got some prepared. Actually, no, these were questions that were put in by people before the event. Can you just explain a little bit more about what does assertive outreach involve? It was touched on in the video.
Hello. Assertive outreach means that you go out to hotspots where people are rough sleeping, and you don't give up. They may say, look, I don't want to hear from you today, go away. That's cool, I'll be back next week. That's cool, we'll be back in 14 days, see you soon. So it's just that not giving up. That's what's assertive about it.
Fantastic. Any other questions from the audience? There's one on streaming.
Dealing with a lot of different agencies, how do you deal with frustration?
How long have you got? No. Look, how do I deal with the frustration? I think you just got to work together, don't you? It's about collaboration, and you need to find ways of working with different agencies with different ethos and different values. And I think the proof is in the pudding with the 50 Lives, 50 Homes project, which I was very strongly involved with setting up here in Perth. And we've got about 49 different agencies that work together. So homelessness is everyone's business, I think, and we've all got a role to play. So sometimes it is frustrating, but you just got to battle on and keep chipping away, as I say.
Very inspirational, Kath.
Really?
Can I call on Denise Glennon, one of our East Metro board members, to present the certificate and pins to the representatives that are here? I think we have to install an applause meter, I think. Our next presentation is by the Hospital Avoidance Response Team of Jacinta Brown, Bethany Leslie, Anthony Hall, Mika Steele and Sue Howlett. Over to the video, please.
Many people with chronic and complex health conditions are at risk for hospital readmission, have less independence, and could benefit from better understanding of their disease and management options. St John of God Midlands Hospital Avoidance Response Team, known as HEART, provides early intervention strategies and case management for patients with chronic and complex health conditions. The multidisciplinary HEART team of clinical nurse, occupational therapist and senior social worker work across the hospital's departments to provide inpatient care and follow-up for patients, with better outcomes for patients being achieved.
HEART, which stands for the Hospital Avoidance Response Team, was instigated as one of our measures to manage the high demand on our services, as well as develop innovative solutions to respond to the challenges of chronic disease within the community. Hospitalisation for many chronic disease conditions are thought to be avoidable if preventative care and early disease management are applied, usually in the ambulatory setting. We are extremely grateful to East Metropolitan Health Service for initially funding the trial, as well as providing ongoing funding so it could become a permanent program for the Midland community.
We identified people that were presenting frequently to the department. We were finding that they were coming back sort of multiple times in a month and weren't being supported in the community necessarily, or didn't have the tools to access all of the different programs in the community. At Midlands, there's been an increased demand for beds since we opened. So we looked at being innovative in ways to address those bed pressures in the emergency department.
We aim to engage patients who have ambulatory care sensitive conditions, so namely patients with cellulitis, who have UTIs, who have diabetes, cardiophilia and pulmonary disease. Patients who largely can be linked into services to better able to manage their conditions, ideally in the community, which would then prevent them from presenting at hospital. We would link those patients in with various community options, link those patients with outpatient services here, engage with the allied health teams, engage with the medical teams, and also engage in the patients' families.
A lot of the patients that we do see have struggled to manage their chronic conditions. A lot of the times their conditions are very complicated. They just need some help managing them.
I think what we do differently is we really put the patient at the centre. Everything that we do is patient focused.
We see them in emergency department, we see them on medical wards, we see them on the rehab wards, and we also do see them on the mental health wards. So I think that really that broad spectrum of we can see a patient wherever they need and to look at what's best for them.
We engage patients in the community. We would provide community follow-up calls post-discharge, just to check in with patients to make sure that any services or any referrals made to external agencies have been met, make sure that patient is generally okay upon discharge, whether they've linked in with a general practitioner.
I think our service has really strengthened community networks, particularly Silver Chains Respiratory Service.
It certainly had a big impact on our patients who have a chronic disease and very complex needs. So these patients actually, they prefer to be managed in a community environment rather than come into a hospital. So the HEART programme works with us to try and encourage these patients to stay at home rather than be brought into hospital. And we look at all their needs to support each and every one of them.
Out of the patients we've had on the program, 85% haven't re-presented unnecessarily. It's decreased the length of stay for these patients in hospital.
Statistically, we've been able to keep more patients out of hospital. Anecdotally, from my patients, I've heard really good things.
They take the time to sit and listen to what's going on and provide advice. If that doesn't work, we explore different things. Having a constant person makes the difference, and they get to know who you are rather than having different people going through my life all over again. I have not encountered another project like HEART while presenting at other hospitals. I like getting calls from HEART caseworkers because it makes me feel that somebody is looking out for me.
Excellence for me would mean providing the best possible quality of care that we can to the patients that we work with. Each individual is different and trying to provide as best a wraparound service as we can.
Excellence is striving to be the best I can through education, through empathy, and through patient-centred care.
Well done, Santiago. Jessica Brown is the person taking questions. Could you please come to the front? Okay, let's open to questions. Any questions from the floor? I have to go to the reserve questions now. How often are you in contact with patients in the community?
It's all sort of patient client driven, so sometimes we might speak to them weekly, sometimes monthly, sort of whatever is sort of required for that individual patient. So it's all, yeah, sometimes it's on a weekly basis.
And as much as it takes, basically, to keep them in the community?
Absolutely, and it's, yeah, sometimes, you know, I have patients where I might, as they discharge, speak to them every day for a week, then it drops back to a week, and then it, yeah, it's all clients, patient-centred, as the other two of my team would probably confirm with me.
And what sort of criteria do you use for discharge from such a program?
That's definitely things that we're working on as we recruit and our capacity builds. Generally, when they get to a point where they no longer require that case management service, where they are linked in with services, they aren't presenting to hospital anymore, when they, yeah, that's probably our main thing, when they're not coming back to hospital, when they're, you know, decide that they want to go into residential care as the other one, or when they are linked back into palliative care services and it's that end stage of their disease.
Great. Denise, did you want to ask?
Do you need to discharge them to GP?
Given the nature of, you know, your chronic diseases, we do link back within GPs and things, but they obviously, that nature, they do come back to hospital. It's more on a case-by-case management. So if they need that case manager and they need that link back in, we continue to monitor them when they come back to hospital. We do liaise with GPs in terms of our discharge summaries. We have an assessment that goes back to the GPs from a communication point of view, but from a discharge from our service, we continue to see in that regard. Yeah.
Fantastic. We do have a question online.
How do you deal with people who don't have access to telephones? Do you do site visits?
We do have that capacity as well. So I don't think I really have anyone that doesn't have a phone between a mobile and a personal a home phone. Looking at my other two members here.
But I haven't had to go out to see him. At the moment, I'm communicating through personal.
Yeah.
But we do have that capacity, and if needs be,
Yeah, family and friends generally are the other key parties that we deal with as well.
Good solution. Ross Keesing, our board member, is about to present you with your pins and certificates. The next video is the Bentley Safety After Hours for everyone, and the team members are Damaris Oakley, Catherine Burkett, Janesh Kundagarden, Joe Cable, Tim Bowles, Alex Jamison, Fiona Bolingbroke, and Sharon Birkenoff. Thank you. Video.
The Be Safe program started in February and provides safe and timely access to care after hours for patients across the Bentley campus. The new multidisciplinary Be Safe team provides 24/7 clinical support for general and mental health patients and staff. Based on worldwide evidence that patients face greater risk of deteriorating overnight, this after-hours team approach means safer care for patients. The Be Safe team provides after-hours staff with extra clinical support, creating an environment where they can escalate care needs and receive additional educational support and greater professional practice opportunities.
I guess one of the key things was having a think about how to, provide that overall 24-hour safe approach. Taking those principles around patients that have been transferred, particularly in the after-hours space, and then taking that, but then looking at Bentley and saying, what are their needs?
The catalyst for Bentley Safe was streamlined with Royal Perth. They've had Safe for a few years now, and also because patient care is 24 hours a day, 7 days a week, and 70% of that time is considered to be after hours. The campus is large at Bentley and quite fragmented between mental health and general health, so we aim to improve collaboration across site. We also sought to decrease patient transfers, supporting general and mental health with the clinical needs of patients to keep them at Bentley. We round the site minimum of twice a day to see everybody, particularly the patients of concern, which enables us to put plans in place. We are aware of the patients who are possibly deteriorating and making solid plans to help them. Be Safe has become the one-stop shop for Bentley, and we are aware of what's happening across the site and can help in a myriad of ways.
The Be Safe team support the staff on the wards by role modelling, providing education and support at the bedside, providing an increase in scope of practice for procedures that they might not have usually done or isn't done often on site.
Improve teamwork and communication, which is the key to every organization to work. Improve the staff satisfaction, provide training and education, and be with them as a support person whenever they require zero harm for patients afterwards.
All of the Be Safe clinical leads have got a wealth of clinical experience which has helped the ward staff. From the time that we've been here, so from February to July, we've had 60 patients that would have previously been transferred to RPH or another hospital which have managed to stay here, which means that we've got less vulnerable patients sitting in ED waiting to be seen.
That's probably the biggest thing. It means that we can actually provide that patient care here rather than them being transferred there and then staying there for a few hours in a busy ED and then coming back again.
I think that the SAFE team have brought a high level of knowledge and medical attention to our patients. Being in the elderly wards, we have a lot of patients who have diabetes, high blood pressure. We do occasionally have falls where people need attention, and the SAFE team have brought immediate help in those situations.
When I look now at our handovers that we receive from Be Safe and see a lot of our mental health patients on there, it's fantastic to see what would have previously been a gap in care, so they're definitely receiving much more comprehensive care.
Be Safe demonstrates excellence by not only setting the highest clinical standard for every patient at Bentley,
but also in the tiny things that they do, in the way they deliver their care. They're kind, they're respectful, and they're bringing all the nursing, doctors and allied health team along on the journey to upskill everybody and make it a better place.
For me, excellence is about exceeding expectations in every way. That's about allowing patients to have outcomes that are better than expected, and the staff to work in an environment where every day they're excited to come to work and provide the care that they know is the best possible.
Excellence to me is not doing what's always been done. We want to continue to strive to improve patient care, and I believe that Be Safe achieves this by questioning the norm, challenging practices, looking at the evidence base and the research available to make sure our patients are getting the best level of care.
How wonderful it is not to have to be put in an ambulance and transferred to Royal Perth ED overnight. That's fantastic. Damaris, help me to answer our questions, please. Questions?
Yeah. Just keep going. Just do not give up. Just turn up. Hi, we're here. Do you need us? No. Yeah. Yeah. We just keep going. Keep going. Don't give up.
I know the collaboration between mental health and general, sorry Nick, the collaboration between the mental health side and general health side has been a huge win for you, but also the depth of skill you've introduced in the general health side has been as well. So what do you think was the biggest impact?
I think the biggest impact has been in mental health. We've certainly, we spend a lot of time there, and it's bringing the site together. I think that's really made a difference. We are going all over the place and we're speaking to all the staff, and we talk about what's happening in mental health and what's happening in general to include everybody in what's happening to Bentley as a site. I think. Anything you guys want to add? Yes.
I think it's really good providing care for patients in the mental health wards that really would have been gone to ED.
A lot. Yeah.
You know, they're staying in mental health and mental health needs to be met with just that kind of physical problems we can't overlook, which is I think that it's really, really good.
Yeah, we do keep a lot of people at Bentley and they get the mental health care they need. That's quite cool.
Sorry, I'm just Alex. I just really want to resonate the great work that it's really being done at Bentley to the benefit of our mental health patients. So all the staff, it's really grateful. So thank you so much. It has been wonderful, a quality improvement initiative. So thank you.
Thank you. Any questions online? Thank you very much. Don't get off yet. Okay, our next video is on peripheral intravenous cannulation team of Sally Simpson, Melvin Kwan, Bianca Perora, Alexandra Cameron and Kazuku Rollison. Thank you.
Healthcare-associated bloodstream infections are associated with increased morbidity and mortality, as well as increased healthcare costs and length of stay. Strategies to prevent bloodstream infections include vigilant hand hygiene and peripheral IV cannulation, or PIVC, practices. In January 2020, Royal Perth Hospital established a safe PIVC team. consisting of 2 registered nurses whose role was to deliver a safer process for managing PIVC at the point of insertion, and to promote and improve monitoring and removal of devices. Under the guidance of this team, a 6-month trial was rolled out in 12 service areas across the hospital.
The PIVC team came about as part of an initiative to look at addressing our hospital-acquired infection rates. Mostly it was because our HABC rate, or hospital-acquired bloodstream infections, was really poor when we benchmarked against hospitals across Australia. We all found that really unacceptable and wanted to look at a new strategy. We actually pulled together a small team of staff and we had them undertake the competency for insertion of a peripheral intravenous catheter. Once they were competent, we set up a structure where they were observed for a while and then they went out there and operated as a team.
With the PIVC team, we had a prime focus of PIVCs and the proper and aseptic techniques surrounding them, educational resources for staff and being available to staff to teach them. They were unsure on how to insert a PIVC, and just being a resource for difficult cannulas as well if staff were unable to insert a difficult cannula.
I think that the positive aspects are actually promoting the importance of cannulation and having a visual presence within the organisation around that. So they've certainly been really positive in being able to troubleshoot, pick up patients that perhaps didn't need a cannula. They've had over 100 patients in the pilot period. They were able to actually challenge and say, why did this patient need a cannula?
It's been a great help to those on the wards, just purely because doctors are so time poor, and having a team that's readily available to put in their cannulas has been a big help, and also to provide them with some feedback on how to care for their cannulas and manage them on the wards.
So we provide timely care as well, and we are there to assist difficult cannulations, where I've encountered some cases where 5 attempts have been made, and patients also are very happy that we're able to come quickly for their medications to be administered. So in a sense, I feel we can make a positive impact in healthcare through timely delivery of IV cannulations.
Successful cannulation can make the patient relax and not so scared of the needles. So those things were really rewarding for me.
From Royal Perth, where we introduced the pilot, we had a reduction in HABCs during that time, which was excellent. And the other thing was that people were very engaged in observing the IV sites and preventing infection. And we had really wonderful feedback from our junior medical staff who normally do the cannulas, and they really loved it and wanted to be taught by the team. So I think it had, multiple benefits across the hospital. I think from a patient experience, these guys got really skilled because they were doing it all day, every day. The other thing that we found with our pilot results is 50% of the cannulas they were deeming as being difficult, yet they had a 95% success rate. PIVC team demonstrated excellence in communication with all members of the ward clinical teams, and that was a huge benefit because they got people on board, which meant we were looking at cannulas and we were removing them and inserting them properly, and that really benefited the safety for the patient.
I think the most rewarding part of the role was being able to meet various people in the hospital and work together with various multidisciplinary teams around the hospital. It was great to really branch out and work with everybody. Also for our patients, ensuring that they are receiving the best possible care.
Linda and Kellyanne. Kellyanne Hahn to take your questions. Michael.
Hi.
We're really interested in this service.
Yeah, we're really interested in this service at Midland. I just wondered a couple of questions. One is, has it been well received? You know, is there any resistance to a service like this, or is it just like everyone wants to see you every day because you provide such a great service? That's question one. And question two was, do you get involved in ongoing management of the cannula, or is it just a one-off service?
So in relation to the first question, I think there's a myriad. There's certainly a recognition and a valid concern around the skilling of the team and over-reliance on a team, as opposed to looking at strategies around how we can deliver this from everyone. And that's certainly something beyond the pilot that we're trying to address the balance in that space. So, you know, I think our feedback's been really great, and the team did an amazing job at the communication and the liaison with everyone to try and get that balance right. But you know, that is certainly a consideration. And the second question was around ongoing management. So that's the next challenge as well, is where do we go from here? Is it looking at things like, you know, patients who've had 6 or 7 cannulas over their journey, and should we be actually thinking about an alternate method of access and all that sort of stuff? So the pilot's finished. We're kind of in a period at the moment of thinking about what are the next steps around sustainability, and there's so many things it could be. What are the core things that the organisation want it to be, and what it needs to address, and how we move that into the future.
Thank you.
That probably leads on to this one a bit. Has the demand for the service exceeded the resources allocated? Sounds great for reducing patient harm. Well done.
Thank you. Yes, so it has, and look, we have had some challenges around sustainability, and that's what we are looking at. And yeah, you know, if you build it, they will come. So we are looking at how we address that and look at I guess striking that balance between what is the role of a specialist team, how do they work with all of us to make sure we're providing that baseline 24/7.
Any other questions? No? And presentation from Ross Keating with your certificates of
Thank you very much.
Thank you. Our next presentation is on organ and tissue donation service. The team would like to be known by all the different areas that they represent. That's Donate Life, Armidale Theatres, Armidale ICU, Armidale ED, and Armidale's Executive Office. Before we go to the video, I need to acknowledge some very important people in the audience. A donor family member, Barry, and transplant recipient Jason. Thank you for coming. Video, please.
In 2015, Armidale joined 10 other hospitals in the Donate Life WA network to support metro organ and tissue donation. Before this time, any potential organ donors had to be transferred to a tertiary hospital to fulfil the donation request. This was not ideal, and some families rejected the transfer or experienced distress or dissatisfaction at an already difficult time for them. Since 2015, Armidale has been able to progress organ and tissue donation on site in a timely manner, with no potential donors needing to be transferred to other hospitals for organ retrieval.
She was just wonderful. We were just about to have our 53rd wedding anniversary. It was totally unexpected. She was fit and well. She did Pilates classes. On this particular day, she had collapsed. It was a burst aneurysm. They did a test to check whether there was any blood flow, and there wasn't. My wife and I were always of the opinion, once you go, you go, and if there's anything useful that can be done with the organs or the body, that should be done.
Currently, there are 1,600 people waiting on the transplant waitlist in Australia, Only 1 to 2% of in-hospital patient deaths can become eligible organ donors. So it is a very rare opportunity. Not everybody can be an organ donor.
It started at Armidale because we'd had a couple of patients who were potential organ donors, and although we got acceptance by the family, the sticking point was the transfer of the patient to a tertiary centre for organ retrieval, which the families were absolutely distraught about. So we felt that we had to push to change the system in WA to allow patients to donate at the hospital that they're potentially going to die in.
Caring for an organ donor entails looking after somebody when they have been declared or close to being declared deceased. It's not only about caring for the patient, but also caring for their family. And as nurses, we need to look after both the patient and the family with care and dignity.
It's about the trust that the family put in us as the theatre team with their loved ones, their most prized, precious possession.
The role of the hospital medical staff is to identify donors early, liaise with Donate Life to initiate the process of donation.
People from the organ donorship were very sensitive, and we all agreed that this was the way to go.
Armidale Hospital is the smallest hospital within the Donate Life WA network. The staffing and resources can be a challenge at times. Since the service was started in 2015, no organ donor has been transferred to another hospital.
Everything seemed to go perfectly. About 2 or 3 months later, we received a letter from Donate Life. It finishes up kind regards from your recipient and points out that it's given him a new life, which is precisely what it was meant to do.
Yeah, it was a pretty emotional day. I still get emotional about it now. Yeah, I was at the shops with my ex-wife. I got the phone call. He goes, "You need to get to the hospital now, we've got a kidney for you." And I just started bawling my eyes out. I went to the counter, I was crying, my ex-wife was crying. The lady at the counter started crying when we told her what was going on. And went home, packed a bag, straight to hospital. I still get emotional about it now. And I was very lucky, but because I was only on dialysis for 4 months. Back at work full time, in a really good place now, healthy, happy, and forever in debt to the dialysis team, the transplant team, or the transplant people, the person who donated their kidney to their family.
Excellence to me means putting myself in the shoes of an organ donor, of their family members, of the staff members, and also of the recipients. Being compassionate and showing empathy at all times related to organ donation.
You need to donate. Simple as that. There's no need to take them with you. Everything can be used again. Give someone else a chance at life that deserves it.
Not much you can say. Nabila Shiab is here to take your questions.
Online, it's a comment just says you must have an incredibly strong and tight-knit team there.
I think so, yes. Thank you. I think we have a brilliant team at Armidale Hospital, and I wouldn't be able to do what I do without the team members that are involved. They are absolutely fantastic. Thank you. And thank you to the teams. And I would like to acknowledge Barry and Jason for coming today to view this video. And this is the first time Barry and Jason have seen the actual full footage, so thank you for coming.
Well done. We do have another question. Does a person have to be a registered organ donor to be eligible to donate?
It helps to be registered. Even if the person is not registered, the family at the end of someone's life get asked the question, and the family has the authority to say yes or no to donation. And even if the person is registered, the family can still say no. So the question depends, the answer is with the family. So that's why it's important to register, as well as have the discussion with the family to make sure that everybody is on board with your decision, because it's a difficult situation to deal with your loved one's end of life. So to have registered and to have had that discussion would give the family an easier, it will make the decision easy on the family. Yes. Thank you.
Thank you. Any other questions? Any more online? Oh, there's one more.
What was the obstacle? Oh, sorry. What was the obstacle in order to achieve this? Was it facilities? Was it skilled staff? Was it authorization? Was it funding?
It's all of it. It's a mixture of, we're a very small hospital compared to the other tertiaries, and we're also quite far out from the metropolitan area. So transferring a patient it also takes a lot of resources and time and skills and staff. But setting it up, I don't think it was a very difficult journey, because from the first time the conversation of setting up the service at Armidale Hospital started, which was in July 2014, we had our first organ donor in 2015 February. So it only took 6 months from the conversations to the actual organ donation service we were able to provide the service to the community. Because the teams are very, very on board. This is something that helps the community. We have seen from Jason's experience that it's something that one can never thank for. Like there's nothing we can say about organ donation that is not helpful to the community. So everyone, all the teams involved in the conversations were on board. Yes, this is something that the community needs. This is something the healthcare system needs. All the burden on the healthcare system, we can help reduce all of that. So the team's involvement and acceptance of organ donation was why it was such an easy process to, get it up and running. Yeah. We do have challenges, yes, but we're happy to move beyond the challenges and work through them. Yes.
Fabulous.
Thank you.
They wanted to do things a little bit differently. Instead of the representatives on the team receiving their certificates and pins, this group wanted the various areas involved to receive a certificate. So Donate Life, Armidale Theatres, Armidale Emergency, Armidale ICU, and Armidale Executive certificate from Ross.
David, can you please come forward? Denver, please come forward. Unfortunately, due to clinical activity, teams from ED and theatre are unable to join us today in person, but they're very appreciative of this acknowledgement. Thank you. Melissa for Donate Life. And Denver will take ED and theatres. Theatre, yep. I'll take the other one. Yes, thank you. Thank you very much.
Wow, I'm just in awe. Before we go through the acknowledgements, can I just firstly get you to put a big round of applause together for the people who put this show on for you today. Nick Dudman, Steve Wise, and Alison Shan, the working group. We keep hearing how good you are. This just proves it. Okay. Thank yous to the East Metro board members for their presence and presentations. Liz McLeod, our CEO, the East Metro Area Executive members, to Michael Hogan from St John of God, our special guests, Barry and Jason, East Metro staff here and also those online, the broader St John of God staff in Midland. Fantastic to have this relationship with you. I was thinking of how to wrap this up, and the only thing that comes to mind is we provide such high quality care, but the video just showed so much kindness in everything that people did. It's something to be proud about working in East Metro. Enjoy the rest of your Monday. Thank you for coming.